First they were the NOACs, or novel or new oral anticoagulants. Then they were no longer quite so new or novel, so they decided overseas they've pretty much adopted the non-vitamin K oral anticoagulant, so they can still use NOAC. Although in this country we're really going, it seems, a little bit more towards the DOACs, or direct oral anticoagulants. Whatever you call them, they are one of the top stories in the last couple of years, and there is a state-of-the-art review in the December 2014 issue of JACC Interventions, and it is on the new drugs and the new concepts, and behind this is first author Dr. Jerrold Levy, MD, who is professor of anesthesiology and associate professor of surgery and co-director of the cardiothoracic ICU at Duke University, one of my favorite places. This is really an interesting topic. It's been now a couple of years. Did you enjoy writing this particular review?
Did you enjoy writing it? So, you know, this is a very interesting topic, near and dear to my heart, specifically because I started out many, many years ago, actually in the late 70s, as a medical resident with the intent of being a hematologist, immunologist. You couldn't make a living as a clotter. It was pretty primitive when you think about it back then. And so I got interested in critical care, ECMO, respiratory failure, went to Mass General, trained as an intensivist, and then was on faculty at Emory for almost 30 years, and then got recruited to Duke over the past about a year and a half ago. But so I've had a very active coagulation research lab at Emory, as well as active clinical efforts looking at bleeding and developing a variety of interesting novel, both purified, recombinant, therapeutic approaches to treat bleeding, from pharmacologic, artificial bloods, and a whole gamut. The impressive thing is that in a heart surgical traumatic injury model and clinical perspective, patients bleed a lot. And one of the interesting things is when you've done this for 30 years, studied it, done research, developed a variety of products, you get a really unique and insightful perspective of the entire importance of both anticoagulation and reversal. The other thing is, you know, in the ICU, 50 to 60% of patients develop atrial fibrillation. So we use a lot of anticoagulations, deal with ECMO, ventricular assist devices. So anticoagulation is critical, but again, bleeding and therapeutic approaches to bleeding has been my interest. So I got very interested in this early on and have been involved with a bunch of parenteral anticoagulants, but obviously when they're also called target-specific oral anticoagulants, DOAC, NOAC, SOACs.
I didn't even bring that one up, but yes, exactly.
But it was clear that it was going to be a very, very important perspective, and having therapeutic options for treating life-threatening hemorrhage. The interesting thing is when you look at the totality of the data with the new oral anticoagulants, the risk of bleeding and life-threatening association is actually less than warfarin. The other thing is that, you know, it's interesting because people have complained for many years that, you know, we don't have reversal agents for the new oral anticoagulants or direct oral anticoagulants. Well, it wasn't until May of 2013 that we had a 4-component prothrombin complex concentrate, or PCC, for the most effective reversal of warfarin. It was available everywhere else in the world, just in the United States. It wasn't until May of 2013. The other interesting thing is low molecular weight heparin, a ubiquitous anticoagulant in a hospital setting. There's no reversal agent currently available for that, and every once in a while you'll see an intracranial hemorrhage, retroperitoneal bleed. And in a greater perspective, you know, you look at the thionopyridines and ticagrelor, they have very long half-lives without reversal agents. So we've lived in this environment for years. There's a lot of interest now in the reversal because of their incredible use. And I think it's really exciting with all of the interesting technology, therapeutic and pharmacologic development underway. And that's been sort of my interest. The review article was a great way to put it all together. And Spencer King asked me, actually, when he heard me give a lecture at one of the meetings, he said, would you be willing to? And I said, absolutely. Now I want to compliment my most excellent co-authors on this, are people who've also been very active in this therapeutic arena. Alex Spyropoulos, Jim Douketis from McMaster, Alex Spyropoulos now from New York, and Samama from Paris, who all have been very, very active in ACCP guidelines and very active in a group that we work with the International Society of Thrombosis of Hemostasis. So I helped spearhead this with their most excellent help. And I think the article, as a result, is not only a great review of many of the different clinical trials, but also therapeutic strategies that are still in evolution. And at this American Heart Association, there have been several interesting papers, discussion, and I was actually the discussant on one of the reversal strategies for edoxaban.
So where are we right now? And what do you think is the take-home message coming out of your paper in JACC Interventions?
Well, the take-home message is that I think the critical component is that people are looking for these antidotes. And when a patient comes in who's bleeding, been hemorrhagic, coagulopathic, the antidote will be, I think, helpful, but clinicians still have to remember to do the basic hemodynamic and hemostatic resuscitation. Fluid expansion, support the blood pressure, patient's anemic, transfuse, the patient's profoundly hypovolemic and bleeding, replete coagulation factors, and think about procoagulant agent. Off-label, these are off-label therapeutic approaches, but there's growing data about their use, about reversing coagulation, testing of anticoagulant reversal. They restore thrombin generation. And in the paper that I discussed today, they actually decrease bleeding using a punch biopsy model. This is the use of 4-component prothrombin complex concentrates. Again, off-label, but you know, in a life-threatening hemorrhage, clinicians need to know all of the data that's out there to make an informed decision. And this particular review article not only reviews all the different clinical studies, but I think offers, again, some additional insight into therapeutic approaches and management.
In the early days, there were questions as to why the uptake of these new agents was as slow here. It would seem to be slower than it was over in Europe, for example. Now, is there any concern that their uptake is a little too fast? Are we doing a good job of being able to manage these new agents?
Well, from a practical perspective, you know, you start warfarin, and it takes 3-4 days before you get your therapeutic level. You adjust the dosage. It goes ups and goes down, and all the issues. But mechanistically, you're reducing the biological levels of factors, where with the direct oral agent, you give a dose, 2 to 4 hours, you're therapeutic. And I mean, as simple as that seems, it's a big deal. Now, one of the things that's been made is that monitoring is not necessary, but if they bleed and there's an issue, all these agents can be monitored. And that's something that we also discuss in detail in the particular paper of how to uniquely monitor either the 10A inhibitors or the direct thrombin inhibitor, dabigatran.
Because standard monitoring is not necessarily going to work. You really have to adapt some of your monitoring approaches in evaluating whether the patient has enough anticoagulation.
But absolutely. But again, there's some basic perspectives that you need to think about in the bleeding patient. And you know, the patient who presents in hemorrhagic shock is a patient who needs certain degrees of resuscitation. And in particular, if you're bleeding extensively and uncontrollably, one of the things we've learned from trauma, from life-threatening hemorrhages, is moving to what's called a massive transfusion protocol, where all the blood losses are replaced with whole blood equivalents. Whole blood's not used, but you use packed cells, plasma, platelets, cryoprecipitate, basically to create sort of a reconstitution of whole blood, but replacing everything's lost. I think that's a critical component that hopefully is also included and understood in the perspectives that we discuss.
Well, thank you for doing this for Dr. King and for the readers of JACC Interventions, because this really is. It's a good state-of-the-art review on the topic. It's in the December 2014 issue, and it's Dr. Levy and his colleagues with direct oral anticoagulants, new drugs, new concepts for now the old coronary and cardio source world news. I'm Executive Editor Rick McGuire.